Get started in just a minute here. Well, it gives me great pleasure to introduce Dr. William HIATT to you. And for many of you, he needs no introduction. He's a giant in the field of vascular medicine. And today we get to stand on his shoulders as he gives us an overview of peripheral arterial disease and clinical trials in peripheral arterial disease. Dr. HIATT has an endowed chair named after him, William R. HIATT Endowed Chair. And he is the professor of cardiovascular research at the University of Colorado. He also is president of a corporate research organization. I say CRO because you know what that term means, but it's actually an academic research organization. So it's Colorado affiliated, and he runs basically all the clinical trials in peripheral arterial disease, doing that for years globally. So he will be able to share that experience with us today. He is associate editor for the journal Vascular Medicine and also for Cochrane Reviews, and he's also participated on the editorial board of JACC and Circulation. Another thing about Will is that he is past chair of the Cardiorenal Advisory Panel for 5 years, 2003 to 2008, and had a lot of interesting experiences with that, chairing that committee. He now is on the FDA Endocrine and Metabolism Advisory Committee. He's an excellent teacher, as you'll learn in a moment. He's received numerous awards for his teaching from his School of Medicine. And he also has been recognized for his research by the American Heart Association with a Distinguished Scientist Award in 2014. That's a major award that the American Heart Association gives to one scientist annually. His research has been in peripheral arterial disease, as I mentioned, the effects of exercise training, pathophysiology and epidemiology of peripheral arterial disease, and of course clinical trials of new therapies for peripheral arterial disease. He's also been a great friend to me for 30 years. 30 years? We knew each other when we were kids, right? No, we met in Boston when we were both training in vascular medicine. And since then, we've been following each other's careers with great interest and really enjoyed the times we've passed across. And thanks for allowing our paths to cross again today. He has over 250 publications in peripheral arterial disease, and he's going to share that wisdom with us today, and maybe actually something else, because another thing that this guy does is he climbs mountains. He's summited every peak over 14,000 feet in Colorado and done Aconcagua and 23,000 feet and others. Amazing guy. Come on up, Will, and tell us about peripheral arterial disease.
John, appreciate it.
Yeah, good to see you.
Yeah, thanks. It's really nice to be here. And as John mentioned, we go back a long time, which has been a fun journey. The vascular world's kind of a small world, and it becomes an extended family. And we still regard each other as kind of brothers and sisters in our work and in our play as well. I think the thing that characterizes me about my time with John is he's a very innovative scientist, and he follows the data, and I really am impressed with your career, John. So it's really a privilege to be here with you. My own clinical research interests, I'll show you here in a moment. It's sort of transitioned from more basic interests in mechanisms of disease in people with peripheral artery disease to developing therapeutics for the disease. My disclosures are that we have a number of research grants that come to my research center, which is part of the University of Colorado, and they come from many sponsors, currently from Bayer, Janssen, AstraZeneca, to name a couple. So that's where the source of some of the data I'll show you today. And then the journey John and I have been on, I tried to find the picture from Aconcagua where his heart bar, which was L-arginine, was featured. So I thought I'd show you what it looks like in western Tibet. That's Mount Kailash, which is a sacred mountain for Hindus and Buddhists, considered to be the home of the Creator. It's an amazing place because it's in western Tibet. There's nothing there. and the plateau is 15,000 feet, and that mountain's 22,000 feet, and that was a journey we took to climb a 25,000 foot peak called Gurla Mandata, and that's kind of me with one of the people journeying around the mountains. These are all extreme experiences. So I'll just try to give you an introduction. Why peripheral artery disease? As you know, it's a manifestation of atherosclerosis in the lower extremity. If you look at its worldwide prevalence, this is a publication from Jerry Folks, an epidemiologist from Edinburgh, actually. And he's looked at the prevalence. It's not just in Western Europe and North America. If you look at other regions in Asia, it's extremely prevalent. So this is a really common disorder with some very kind of unique manifestations. And the thing that gets your attention are these event rates. So when we take various cardiovascular populations, like an acute coronary syndrome patient, people with chronic stable coronary disease, prior ischemic stroke, you put PAD in that mix, and look at 1 year outcomes in this patient population. Cardiovascular death, almost 2% in a year. Non-CV death, 1.5%. Myocardial infarction, 2%. Acute limb ischemia, over 1%, and amputation, about 1%. So we call these major adverse cardiac events, MACE, and now we have a new term, major adverse limb events, MALE, which is an adverse event for some people anyway. But these last two things, acute limb ischemia, major amputation, are targets of therapy now that have been modifiable. So most of what we know in cardiovascular medicine in terms of secondary prevention, whether it's antithrombotic drugs, aspirin, clopidogrel, dual antiplatelet therapy, ticagrelor, you go through that list, or with statins and metabolic agents, blood pressure control. It's about identifying people with coronary disease and targeting them for therapies. And PAD tends to be a rider that comes along with that. And so when I think about developing therapies for peripheral artery disease, that presents some unique challenges. And I think going through this journey in terms of the history, most of that evidence that we have today comes from patients as subgroups of coronary populations. And you think, well, does that matter? And it turns out it makes a huge difference in when you look at the outcomes. What we're trying to prevent is not just cardiac events, but also these major adverse limb events, which are actually as bad as having an MI. So acute limb ischemia in the leg is like having a myocardial infarction in the heart, and the subsequent risk for subsequent MI, stroke, death, and limb loss is higher than if you'd had an MI. So it's actually worse to have a blood clot in the leg, I think. And I think that these become modifiable events with some of the new data, but interpreting that new data I find still challenging. So in terms of these endpoints, here's what happens after a blood clot in the leg. Now, any vascular surgeons here? And you've treated acute limb ischemia? So you get the call in the middle of the night, it's a cold leg, you angio that patient, open up usually a thrombotic occlusion, and you think that's just a leg event. But if you look at 1 year later, 2 years, this is 2 year data, 11% have a subsequent MACE event after an acute limb ischemia event, 12% die, 25% have recurrent limb ischemia, and a bunch get more recurrent interventions. So acute limb ischemia is actually worse than having an MI that you recover from. So but it's an endpoint that is just now newly recognized. And something the FDA actually agrees with. They agreed this is an important endpoint in our clinical trials. So our current recommendations for therapy in peripheral artery disease, shown here from the latest ACCHA, it talks about antiplatelet therapy, and kind of puts aspirin and clopidogrel as equivalent agents to treat people with peripheral artery disease to prevent MACE events primarily. So that's that 1A recommendation. And dual antiplatelet therapy in stable disease has a 2B recommendation to reduce cardiovascular events as well. So you think, oh, that seems familiar, why not? But I don't think these recommendations are actually grounded in the evidence, and I think interpreting the evidence is what I want to focus on for the rest of this hour. So when you start with antithrombotic therapies, and what's the evidence for that, we'll start with aspirin. Aspirin is like, it's sort of unassailable in cardiovascular medicine. Although if you look at the primary prevention literature, it's kind of underwhelming. Secondary prevention, it's actually pretty strong. But then let's turn our attention to peripheral artery disease. And we did a meta-analysis in JAMA about 8 years ago, looking at all the trials where aspirin was given, or aspirin plus dipyridamole, to people with primarily peripheral artery disease. And there's only 438 vascular events in 46 trials. So there's not a lot of events. It's not like a big mega trial. And if you look at the hazard ratio on MACE, it's 0.75, but it's not statistically significant. And in asymptomatic disease, more recent publications by Jerry Folks, another guy from Edinburgh, that hazard ratio is 1.03. So there's just not much evidence for aspirin's effectiveness in PAD. And so despite the AHA recommendations, a colleague and I wrote a perspective piece a couple of months ago in Circulation saying that aspirin monotherapy should not be recommended for cardioprotection in patients with symptomatic peripheral artery disease. And I think that the reality is the evidence doesn't support it. And so now what do you do? I mean, the aspirin's off the table? Well, that's the actual meta-analysis, and at the very bottom here is this confidence interval. That's across more trials, and it has a hazard ratio of 0.88, but still not statistically significant. So aspirin looks like it might have some benefit, but it's just underwhelming. There's just not a lot to go for it. We need something better. So also a journey through history. The Capri trial, I remember being at the AHA 21 years ago when it was presented. It was pretty impressive. You probably all recall with 3 different populations, a stable disease, coronary disease, prior stroke, or for the first time, peripheral artery disease. And the overall trial had a modestly statistically significant effect on MACE events, had risk reduction of 8.7%. But there was a huge reduction in peripheral artery disease. And that seemed to drive the results. And so I think that got people's attention. And it looks like clopidogrel may be more effective than aspirin from this single trial. But it also looks like PAD is an effect modifier. It actually drives the results. But when you look at PAD, most of these patients also had concomitant coronary disease. So when you look at this forest plot, and you see the PAD result off to the right, and you say, wow, that's striking. And that has a positive statistical interaction, meaning that that's probably a real difference. What's driving that? Is it because it's PAD, or is it because it's polyvascular disease, it's PAD plus coronary disease? It's a little hard to tell. So is this better in PAD simply because it works differently in people with atherosclerosis in the leg who die of heart disease? Or is it the fact that you have multiple circulations, multiple vascular territories affected? And that question, I think, was never effectively answered because for a long time after this came out, the sponsors didn't want to do any more research because they thought they would maybe mess up these results. So that's where we stood until we got to dual antiplatelet therapy, and that led to the Charisma trial, which came out about a decade later, 15,000 patients, same kind of population. But instead of just giving aspirin or clopidogrel, they were randomized to aspirin plus clopidogrel versus aspirin alone. And there was a broad population of patients. Unfortunately, that trial was not positive either. The hazard ratio was 0.93, not impressive. Upper bound 1.05, so not statistically significant. In PAD, the hazard ratio is kind of the same, 0.87, upper bound 1.13. So it looked like intensifying antiplatelet therapy in peripheral artery disease was no better than clopidogrel alone. In fact, it's kind of weird, isn't it? I mean, why would clopidogrel beat aspirin so cleanly in Capri and clopidogrel plus aspirin not beat aspirin so cleanly in Charisma? And that's the forest plot there. And the results in the PAD group are right here. And you'd say, well, that goes in the right direction, as do all these points. But a hazard ratio of 0.87, I must say, if you want to develop a new drug, you don't want a 13% risk reduction. That's just not enough. And so I still find this kind of hard to interpret because if clopidogrel is maybe better than aspirin, shouldn't adding aspirin to clopidogrel at least retain that benefit? But that's where we were over the last 2 decades in terms of developing treatments for people with PAD. In both of these examples, PAD is a subgroup. It's not a standalone population. And then more recently, I don't know if you all remember Prodigy. That was a while ago, but that was looking at short course, long course, dual antiplatelet therapy in people with coronary disease, having coronary stents. And they did a subgroup analysis of PAD. And it turns out the benefits seem to be retained in the PAD people in terms of MACE outcomes. So this is coronary stenting, MACE outcome, PAD as a subgroup. And you can see in this figure that the DAPT strategy, prolonged DAPT, was better than short DAPT, and there was a positive interaction there, only in the PAD plus CAD subgroup. So maybe in this case, PAD is a driver, or maybe it's just polyvascular disease again, it's more severe disease, and now you see something going on in PAD plus CAD. But again, I think it's hard to know without standalone trials what the evidence really is and what we should be doing. And I'm not recommending dual antiplatelet therapy, particularly in stable PAD, but we do it all the time in people with coronary stents, and we have new guidelines about that. So. But it just suggests that PAD may be an effect modifier here as well. So since those early studies, I want to go through these trials, and I'll do these individually. But I think to sort of go through this list, it highlights the same discussion we just had. So Plato was an acute coronary syndrome trial. It was ticagrelor versus clopidogrel on a background of aspirin. So ACS is a high-risk event. It was a positive trial overall and included a PAD subgroup. Pegasus was ticagrelor plus aspirin versus aspirin alone in a stable coronary population. That had a positive PAD subgroup result. And that Euclid trial I ran, almost 14,000 patients, was a flat-out negative trial, clopidogrel versus ticagrelor. We'll go through that. And then we get into Vora-paxar. And lastly, I'll finish up with rivaroxaban, which actually does have some exciting data. So in ACS patients, Plato was published several years ago, and after a long deliberation by the FDA, was finally approved. The concern was a treatment by country interaction. The drug didn't seem to work too well in North America. That got sorted out, and the drug got approved. So in this 18,000 patient trial, only 1,144 had peripheral artery disease. And the comparator, as I said, was ticagrelor versus clopidogrel on aspirin. So DAPT in both groups, if you will. Having PAD drives up the MACE event rate a lot, 19% versus 10% across the trial. And in that study, in the PAD subgroup, the MACE hazard ratio was 0.85, and there was a mortality benefit as well. But again, this is not PAD alone. This is PAD in the context of acute coronary syndrome, so it's a polyvascular population. And that's a Kaplan-Meier curve showing the results, and I think it's impressive. And it suggests in this situation, if you have an ACS event and you have PAD, adding ticagrelor is probably a good idea compared with clopidogrel. And if you have PAD, it seems to confer benefit in that patient population as well. Pegasus followed on that. That's a stable coronary population. 21,000 patients, a big trial. These are high-risk post-MI patients, and it too had 1,100 patients with PAD. But all those people had coronary disease, so 100%. So this is another polyvascular population. As I mentioned, there was ticagrelor, 2 doses, plus aspirin versus aspirin alone. So background aspirin in both groups. And the subgroup of PAD had an increased risk for MACE, as well as acute limb ischemia. And this is where looking at these limb endpoints was started to become a focus. And that, I give tribute to Mark Banaka at the Brigham and Women's Hospital, who's one of your competitors for the AHA Strategic Network grant. So he's done a lot of this ALI work in terms of understanding there. So in that population, looking at the MACE risk, the way he's shown this is if you have no PAD on the bottom here, you can see that that there's the placebo and the drug effect down here with a hazard ratio of 0.86. But if you add peripheral artery disease, you get a huge bump in event rates. So in all of these trials, polyvascular disease like doubles your risk of a MACE event. And the 3 vascular territories makes it even higher. So the more territories affected, the higher the risk. And then when you have a hazard ratio of 0.75, which is a little stronger than 0.86, you actually have a bigger absolute risk reduction. So that actually, the number needed to treat is very favorable. And this was, there's no interaction. So these results are consistent with the overall population, but you get more bang for your buck if you have PAD plus coronary disease, and you give people ticagrelor plus aspirin versus aspirin alone. Absolute risk reduction, 4% number needed to treat 25. That's pretty good. And then here, in terms of this literature, acute limb ischemia, this is major adverse limb events, which is both that and amputations and complex vascular surgical reconstruction. You can see a hazard ratio of 0.65. It's pretty impressive. And when you see the other studies I'll show you, the reduction in limb events with these antithrombotic therapies is really stronger and more impressive than it is the MACE benefit. So here, a hazard ratio of 0.65, you can see those event rates. What's interesting, and we always sort of focus on this, when do the curves separate? So not much action up to about a year, and then the curves separate after that. That's not consistently seen. I'll show you other data in a minute where the curves tend to separate quite early. So in this setting, if you have coronary disease and peripheral disease, then ticagrelor plus aspirin is better than aspirin for both cardiac and limb events. And the effect on limb events was really quite impressive. So that brings me to the Euclid trial. So we thought we finally had our opportunity to change the world. And that was a study that we actually published a year ago and presented at AHA last year. So we enrolled patients with symptomatic peripheral artery disease. We randomized them to ticagrelor versus clopidogrel. So when you go to the FDA and present your study design, they said, why not aspirin? And the answer was, well, I'm not sure aspirin's the best comparator. Let's compare it to something that's pretty powerful, that actually may work. And so we kind of had to reference back to those Capri data, and that's why we picked clopidogrel. Now, I argued for a third arm. I thought an aspirin arm would have been terrific, right? Because then you have comparative effectiveness. 2 P2Y12 drugs versus aspirin would have been terrific. It would have not been that many more patients, but of course the sponsor said, no, we don't want to pay for that. In terms of the design, we excluded people who couldn't metabolize clopidogrel, the CYP2C19 polymorphism. By the way, we screen for that in our cath lab now. Do you? No. Yeah, we biobank everybody. We screen CYP2C19, and before they go to the lab, we know that if they are homozygous for the poor metabolizer status. And then we included 2 populations. So either you came in because you had low ankle brachial index, meaning you have disease in the leg, or you came in because you had a prior lower extremity revascularization. Either one of those got you into the trial. As an event-driven trial, MACE was the primary endpoint. TIMI major bleeding was the primary safety endpoint. And I want to point out, when you take a population of people who predominantly present with peripheral disease, what do they look like? Well, only 29% had coronary disease. And so that's a small number. And all the studies I've shown you to date, 100% had coronary disease or the vast majority. But when you take PAD on its own merits and just enroll people with symptomatic leg disease, the vast majority have not had a myocardial infarction. They will. That's why you put them in the study. And they will have a stroke. Number of vascular beds affected, so just 1 means you have PAD. That's over half. 2 vascular beds, which could be either carotid or coronary, 30%, and 3 beds, 10%. The other thing you'll notice is diabetes is extremely common, more common than you see, I think, in coronary populations. Almost 40% had predominantly type 2 diabetes. So that's what they look like. They look different than a population with a prior MI, stable coronary disease, prior coronary intervention. And what happened was kind of a disappointment. That's the clopidogrel KM curve, and that's ticagrelor. It's like totally overlapping. And I think it has their ratios there. That was a bad day. We were at Duke. This trial was run by my organization at Duke, DCRI, and man, we thought we had a winner. And we, Manesh Patel, if you know him, we just looked at these data. It was like, God. So since then, we've been publishing natural history papers, which has been great. But this didn't move the field forward. So what about that? Where do we stand now? Because we talked about aspirin. Now we're talking about P2Y12. And clopidogrel through ADP is essentially a P2Y12 antagonist. So if you look at the evidence, I think that if you intensify P2Y12 inhibition, which ticagrelor clearly does, and in certain settings, like in ACS, it clearly confers a benefit. So intensifying, blocking that pathway is clinically beneficial under certain circumstances. And in that setting, ticagrelor plus aspirin, which is 2 drugs, is effective to prevent MACE in ACS, and it's effective to prevent MACE and major adverse limb events in people with stable coronary disease. The difference is, in Pegasus, it's not DAPT in both groups. It's aspirin in one group and DAPT in the other, and the DAPT is ticagrelor, not clopidogrel. And in both of these populations, ticagrelor seems to work quite well if you have coronary disease and you take 2 drugs, which looks different than that, doesn't it? So in terms of ticagrelor as a benefit, when would you use it? I guess I would use it in someone who has PAD and coronary disease, and I would probably give it with aspirin. But ticagrelor monotherapy in PAD was no better than clopidogrel, and so I think coronary disease is a strong effect modifier. So if you want to use ticagrelor and you have PAD, I think you should make sure there's clinical evidence of coronary disease. If it looks like the Euclid population and it's just PAD on its own and use ticagrelor on its own, I think it's an acceptable alternative if you can't metabolize clopidogrel. But in terms of a primary choice, you can't really defend it. I wish we'd done a non-inferiority design, but we weren't planning for that either. So moving into different mechanisms, and these are still antithrombotic drugs. I'm not sure anybody uses this drug. We do occasionally. Does anybody use Vora-paxar? You do? Once. Yeah. My colleague, who does all our peripheral work, used it once, and he didn't give it with aspirin or anything, and it didn't seem to help. So you got to give it with aspirin or clopidogrel. So it blocks the thrombin receptor on platelets. It's kind of an intersection between thrombosis and antiplatelet effects. There are 2 trials. I won't talk too much about TRACER, but TRA2P, 26,000 patient trial, predominantly people with a prior MI, ischemic stroke, or almost 4,000 with symptomatic peripheral artery disease. The stroke arm was dropped during the trial by the data monitoring committee because of excessive intracranial bleeding, and so there was a major safety concern, and bleeding is a concern with this drug. Now, in this PAD cohort, these almost 4,000 patients, over half had concomitant coronary disease. It should be CAD, not PAD. And Vora-paxar was not given alone. It was given on a background of mainly aspirin, but also dual antiplatelet therapy. And in the PAD subgroup, depending upon which publication you look at, the effect on MACE was not very strong, but it was consistent with the overall results. So this is the overall result here, which did show a significant reduction in MACE events. And it got the drug labeled on the market, and it includes PAD in the label. But this is where I think people really got excited, because this drug, when you look at peripheral limb events, was really quite effective. This is, again, Mark Banaka's work. So if you look on the left-hand panel, hospitalization for acute limb ischemia. So that's an acute thrombotic episode in the leg, requires admission, and requires an intervention or the leg comes off. In that situation, Vora-paxar, look at these curves. I mean, they just separate. There's no events in the Vora-paxar arm for the first, 6 months or so. And then the curves are widely dispergent. and the hazard ratio is 0.58. I mean, that's a dramatic effect. And then when you look at this curve, limb revascularization, these are both elective and urgent. Those curves separate late, but it still reduces people's symptomatic disease, because what drives you to get a peripheral revascularization is usually claudication or some limb symptom. Try not to treat asymptomatic disease. So there's something about this drug that has some powerful effect on limb events. And if you look at what happens in acute limb ischemia, this overall hazard ratio of 0.58, but graft thrombosis is reduced. So surgically, when you do a prosthetic bypass or a vein bypass, we're worried about graft thrombosis. In situ thrombosis, stent thrombosis, and I can't read that last word, thromboembolic, I think. All thrombosis is reduced by this drug. And I'm not promoting Vora-paxar. I don't think there's a huge role for that in clinical medicine today. But it shows you mechanistically, if you go to where platelets and thrombosis intersect, and you block a specific pathway, and you take a high-risk group of patients, and you look at the leg, remarkable stuff is happening. And these reductions are not just clinically significant, they're really clinically significant. I mean, cutting your risk of acute limb ischemia in half is a big deal. So I think our insight in terms of therapeutics and what should we be looking at and where we're going to get to in a minute is informed by these data. So it has a modest effect on base. It does increase bleeding, so there's clearly a trade-off. It's not given as a standalone drug. What's really amazing is that it reduces ischemic limb events. And I think that's where the light goes on. ALI and amputation are bad things, worse than having a heart attack. And now we have therapies that massively reduce that risk. So then the next approach is this sort of inhibiting two different pathways. And I do think this is novel, and I think this is going to change how we approach not just cardiovascular medicine, but clearly patients with peripheral atherosclerosis. So blocking platelets and blocking thrombin. I think together that is actually the DAPT of the future. Up until now, it's been more and more focused on the platelet. Vora-paxar maybe crosses over a little bit, and now I think the idea of low doses of antithrombotic combined with aspirin provides really some very interesting results. And I'm sure you've seen these data. They've been presented at European Society of Cardiology last August, published in the New England Journal of Medicine, and then in Lancet, the PAD subgroup was published by Sonia Anand just a month ago. So COMPASS was run by PHRI, Salim Yusuf's group, 27,000 patients with coronary disease, 7,000 had coronary plus peripheral. And overall in the population, 90% had coronary disease. So we're stuck with the same challenge. It's not PAD alone, it's PAD with coronary disease. How do you separate the two? You do Euclid, and that was negative. The dosing paradigms were rivaroxaban twice daily, 2.5, very low dose, plus aspirin, 100 milligrams, or rivaroxaban alone without aspirin versus aspirin alone. So 3 arms, 2 different dosing strategies, a great novel design. And if you look at the pharmacokinetics of 2.5 milligrams of rivaroxaban, it does have an effect on factor Xa. It does have an antithrombin effect at this dose, but that effect's gone in 12 hours. So you have to give it twice daily. So if you look at those PK curves, they really come back down almost to 0 after 12 hours. So the good news is if someone bleeds on this, just wait a couple hours and their bleeding risk should be no longer driven by the drug. So the overall COMPASS results are shown here. This is the Kaplan-Meier curve for the MACE endpoint. That's aspirin on top. The rivaroxaban alone arm, which started to separate, but took a long time, and it had a hazard ratio of 0.90, and it wasn't statistically significant. The trial was stopped early. Had the trial continued to completion, it probably would have been significant. And then the arm that really won was rivaroxaban 2.5 plus aspirin, and that had a hazard ratio of 0.76 on MACE, and that was highly statistically significant. So that's impressive. And the overall event rate in this population was low. To get that much of a reduction in a well-treated, low-risk population is really even more impressive. So what's modifying the effect in COMPASS in this subgroup that won? In the people with coronary disease, which is 90% of the population, the hazard ratio is 0.74. But in the 10% of people who had no coronary disease, they had mainly PAD or carotid disease, the hazard ratio is 0.89. So once again, is it coronary disease? And just adding PAD is a way to enhance risk and show more benefit. If you do PAD alone, you can't answer that question from COMPASS. But it does seem that having coronary disease is an effect modifier. So when we look at the PAD subgroup, this is the MACE and male effect. So the MACE effect in the PAD subgroup looks just like the overall effect in the population. No surprise, because they aren't that different. They all have coronary disease, and these people have coronary plus peripheral. That's the 2.5 milligram line on the bottom, and that's clearly beneficial, hazard ratio 0.72. Major adverse limb events, that's where the new action is, and that has a hazard ratio of 0.67, and that's wildly significant. It was actually better for the 2.5 versus the 5 milligram arm. But once again, like Vora-paxar, we're seeing limb events remarkably responsive to this dosing strategy. So in the PAD subgroup, the MACE effect, hazard ratio 0.72, upper bound 0.90, highly statistically significant. Acute limb ischemia, hazard ratio 0.56, 50% reduction. Major amputation, 70% reduction. Imagine, 70% reduction. Now, there's not a lot of events, so it's got wide confidence intervals, but jeepers, that's impressive. And major adverse limb events, you sort of put ALI and major amputation and complex revascularization, 0.54. So if you see those results and you're a vascular surgeon, interventional cardiologist treating peripheral disease, you'd say, wow, I think that's kind of an amazing treatment. Maybe we should look into that further. And I'll show you the study we're doing right now. But I just think that this is kind of an amazing time for us to have these kind of therapeutic effects. So combining factor Xa inhibition with cyclooxygenase inhibition, rivaroxaban plus aspirin, is effective in reducing both male and MACE. I think coronary disease remains a major effect modifier for MACE in people with peripheral disease. So all the evidence I'm showing you, I think the dominant theme is if you have peripheral disease with coronary disease, you're likely to respond to ticagrelor, clopidogrel, to Vora-paxar, and to rivaroxaban. But PAD is what drives the male risk. And when we look at subgroup analyses of Euclid that we're publishing now, the risk of acute limb events is based on the fact you have disease in the leg. That's the main driver. So antithrombotic therapy, this PAD has a high risk for male and MACE. I think it's polyvascular disease driven. I think that in most of our evidence, it's PAD is a subgroup of a larger cardiovascular outcome trial. There's background antiplatelet therapy in all these trials. And it's difficult to sort out the effect of coronary disease and peripheral disease versus peripheral disease alone. But as I showed you, if you look at PAD alone, you're looking at a population with not much coronary disease. So aspirin is not that effective, I don't think. I don't recommend it. I do think clopidogrel is probably more effective. It's old data, but as monotherapy, I think it's still defensible. Vora-paxar, I think, has remarkable limb events. So in our clinical practice, we do use Vora-paxar in those patients who've had peripheral interventions. We're worried about recurrent ALI risk and things like that. And then ticagrelor is effective only in the setting of having coronary disease. It doesn't seem to have any greater benefit over clopidogrel in the setting of pure peripheral disease. So in my last comment on this is that prior interventions actually raise your risk of acute limb ischemia. And from Euclid, that's a 4-fold increased risk. And so based on that and based on COMPASS, we've been running what's called the Voyager trial, looking at low-dose rivaroxaban plus aspirin immediately after peripheral, endovascular, or surgical intervention. And so this is a pure PAD population, but we're looking at it in the setting of a high-risk event. So we've talked this morning mostly about people over in this window where this line is the MACE risk and the limb risk. And over here, all the data I showed you is kind of down in this sort of lower risk category. But when you put a patient in the cath lab or take them to the OR, their risk of cardiac and limb events goes way up. And so we want to test a treatment strategy in that setting, and that's what we're looking at now. And that's the design of the Voyager trial. It's randomization to rivaroxaban or placebo on a background of aspirin. And the primary endpoint is MACE, MI, stroke, vascular death, acute limb ischemia, major amputation of a vascular cause. This will likely probably read out in the next 15 months or so, I would think. We'll be done about a year from now with getting our event. So we'll probably wrap this up early 2019. Last comment, what's new? 2 minutes. Foyer. This is evolucumab, and this is a subgroup analysis of the Foyer trial, and I'll just show you the effects. In PAD, it has a major effect on MACE, but here it is again. These are the major adverse limb events, and somehow intensive LDL reduction does the same thing. So stay tuned. I'll stop with that, but I think it's an exciting time to be in this world. I think we have new therapeutics coming along finally, and this is kind of where we've gotten to, how we've gotten there. So thank you very much.
Thanks, Will. That was great. I have some questions. Let me start with one. Will, we talked a little bit about acute limb ischemia.
Yeah.
And let's talk about that a little bit. In the world of the cardiologist, acute events, acute ischemia, coronary ischemia, there's about 750,000, a million events every year. In the peripheral circulation, there's 40,000. So there's a little discordance there because peripheral arterial disease is almost as common as coronary artery disease in this country, yet acute limb ischemia is very rare.
Okay.
These diseases are both due to atherosclerosis.
Right.
What are your thoughts about why we see so much acute coronary syndrome, whereas we see very little acute limb ischemia?
So John's asking about acute limb ischemia and why there's a discrepancy in prevalence. I mean, clearly coronary disease remains the #1 target, I think, for therapy and drives most of the events. Having coronary disease without peripheral disease is not a driver of acute limb ischemia. So to answer your question to begin with, you've got to have disease in the leg to get acute limb ischemia. There are a few thromboembolic events from atrial fibrillation and arrhythmias that come from the heart. They go through a pristine vascular system and wind up in the leg, and we see that occasionally. It's not very common. But if you enroll coronary populations, you're not going to see much acute limb ischemia. But if you do an intervention, I think that's where I'm struck. The Euclid study, we published this in Circ a year ago. If you've done a peripheral intervention even 3 or 4 years ago, your risk of acute limb ischemia has increased 4-fold. So the driver of acute limb ischemia today is the cath lab and the OR suite. And that's the patients who are at risk. So it may be only 40,000, but the people that are really high risk, and that's in this curve here, this high risk has to do with intervention. I think the action for acute limb ischemia, where we're going to prevent it, is in the cath lab. And so if we don't treat everybody, but if we say, if you're going to go for your treat for your CLI or for your claudication, and we're going to do an SFA procedure, fair enough. But then you probably need to this ALI risk. That's something now could be today, low-dose rivaroxaban plus aspirin, could be intensive LDL reduction. And when we finish the Voyager trial, it will probably be low-dose rivaroxaban at the time. You start it right after you've had hemostasis after the procedure. So I think you do it immediately because the highest risk is like that day. And the bleeding risk is quite low.
Okay, you're the boss. No, Alan's the
That's
boss.
okay. So because it's relevant to what you were saying, is that acute limb ischemia is a relatively uncommon event. And I'm glad you touched on the most common reason we deal with acute limb ischemia events is because of inappropriate intervention that really didn't need to be done in the first place.
That's for sure.
Yeah, I know that. No, that's the problem with the mentality, unfortunately. It's pretty pervasive, actually. And so, so it breaks down into two groups. It is pretty uncommon to get acute ischemia from slowly progressive peripheral arterial disease. In fact, it's remarkably uncommon. And those are the patients who actually tolerate it relatively well. The ones that we see basically have either been intervened on, got the groin screwed up, or they had thrombosed the bypass graft or something like that. So I think it's real important that we kind of understand that. But my question for you really was about, we tend to think of lower extremity atherosclerosis in two different categories. And we think of the burden of atherosclerosis relative to those categories. There's SFA disease, which is relatively benign. And that's where the problems are happening. They're getting intervened on all the time. And they don't need to be intervened on most of the time. And then there's popliteal and distal, which tends to be the diabetic population where is very difficult. I mean, these patients, the high disease burden, they're the high MACE and Mayo rates, basically, that we're dealing with. But it's all kind of lumped together in these. I didn't hear the distinction between the aortic occlusive disease, SFA occlusive disease, which is pretty benign in terms of the influence on the leg, versus popliteal and distal.
Great. I completely agree. So, I mean, the whole gradient, when you look at inflow disease, aortoiliac, you're dealing with large vessel atherosclerosis. SFA, there's a lot of disease, and then when you get below the popliteals, you're into tibials, and they behave very differently. And patients lose their leg when they have no tibial outflow. So I think the whole clinical manifestation and how we look at it clinically, and what we sit there, when we're in clinic and looking at our caseload, which includes a lot of CLI and symptomatic disease, it's a lot about the anatomy and how we're going to treat it. And the action is how can we do more limb salvage work and more peripheral work. If you look at the kind of the medical therapy, like what do we treat these people with? Is it just aspirin? You know, I think these new treatments, so the idea of low-dose antithrombotic, low-dose aspirin, is going to apply to all these people. I've not seen subgroups in CLI. I don't know if they're a responder in this case or not. I will know that in Voyager because we've been enrolling a lot of CLI, critical limb ischemia. So what we need is a therapy that's tailored to those patients, and we need to be able to look at all the SFAs versus all the distals. And I'll be able to do that in about a year. But I think you're absolutely right. It's not the same disease everywhere.
So a comment and two questions. So great lecture. I think your comment that Euclid did not move the field forward is incorrect.
If I was a PI, I would agree with you.
Yeah, I know, but you know, you're talking to young, impressionable people like Dr. Lumsden. You know, it's a negative trial. It taught us an important thing about P2Y12 monotherapy.
Yes, it did.
We're not going to be putting patients on cangrelor for weeks now because of what we know about ticagrelor.
Yeah.
Questions. So number one, do you think PAD is simply a marker of a risk-enriched population, or do you think, you know, maybe it sets up a situation where red cells get beaten up and release enough ADP to become mechanistically different than it is in, you know, and more susceptible to P2Y12 modification than in patients who don't have PAD?
Thank you. Just to
It's
comment.
not an original thought. It's
Well-
Carlo Petrono's, and he's almost never wrong.
What we say about Euclid is we failed to meet the primary endpoint. We went up against an active comparator that was active. And so whatever was going on in the clopidogrel arm was probably as active as what was going on in ticagrelor. And intensifying that pathway with monotherapy was no more effective. Had we had aspirin or placebo, it would have been wildly beneficial. So I agree with you. Didn't meet its primary endpoint. We're going to learn a lot from Euclid. And I think you learn about what works in what population, and it's not all the same. So is PAD different? Yeah, I think it is. When it comes to the MACE risk, it probably isn't that different. But when it comes to all these leg events, it's all driven by PAD. So if you have coronary disease and you're not symptomatic in the lower extremity, your risk of having acute limb ischemia, amputation, et cetera, is very, very low. But if you have disease in the leg, and particularly prior disease that's been intervened on, your risk goes way up. And so the difference about PAD in my mind is the actions in the lower extremity. And that's where these therapeutics have to work, and that's where we need dedicated trials.
So my other question is your thoughts on low-dose 10A inhibition.
Yeah,
I mean, it's really curious. Vora-paxar failed in acute coronary syndromes,
right.
which has always been the platelet domain
Yep.
until that happened. But it works in the chronic situation, which has always been the soluble coagulation domain. And, you know, that seems to be augmented by 10A story.
Mm-hmm.
What do you think is going to happen in the acute setting? Do you think,
Here?
yeah, in Voyager? Because now we're looking at soluble coagulation rather than the platelet story.
Wow. Well, I'd like to think we're sitting on some pretty hot positive trial that's going to be a game changer. But there are ways to temper that enthusiasm. So if you look at COMPASS and you look at the subgroup of people with PAD who don't have coronary disease, there are not many, it's not published, it's not as interesting. I don't want to say too much. I worry about Voyager only in the sense that only about 40% of people in Voyager have clinical coronary disease. And so all this thing we talked about earlier, does it take coronary disease to drive the MACE benefit? It might. Now in the acute setting, that MACE risk goes up too. And our MACE event rate in Voyager is healthy, but our limb event rate is huge. Huge. I mean, I can't really tell you what those numbers are, but they are higher than we ever projected. And we went to the FDA with a 7.5% event rate, and we've exceeded that a lot. So, what's driving it? It's acute limb ischemia and major amputation of a vascular cause. I think those are very modifiable events with low-dose factor Xa inhibition and aspirin. I think that's going to be an amazing result. I just think that is just such a rich acute thrombotic milieu where antithrombotic therapies probably make sense. But we'll see.
Dr. Hyatt, when we think about coronary artery disease, we don't stop at the vasculature. We think about the microvasculature, we think about the organ, and the benefits rest around medical management, which is avoiding remodeling and negative remodeling. When we think about PAD, we're not thinking about the smooth muscle or the tissue. And if you look at all the therapeutics, are we not looking at the disease in the right way? And should we be studying the tissue and medications that actually make a difference in the microvasculature versus just focusing on platelets and thrombotics?
Absolutely. And that's a different talk, which is treating symptomatic disease, I think. Earlier in my career, I did a lot of muscle biopsies in these people before and after exercise and looked at the more mechanistic pathways. And so a claudication is ischemia reperfusion. That causes endothelial damage, but it also causes mitochondrial damage. And electron transport is very sensitive, particularly complexes 1 and 3, to ischemia reperfusion, oxidant stress. And so electron transport takes a hit. That means oxidative phosphorylation is impaired. It's clearly impaired in PAD muscle. And so that's a target for therapy. Now, what works for that? You know, cilostazol, it's not much new going on there. I was part of the Clinical Trials Cell Therapy Network, CCTRN, and there, an alt-bright cell therapy didn't seem to be that effective. There's not as much interest, quite frankly, in developing treatments for that end organ, but you're absolutely right. It's not just occlusive disease, it's all this downstream stuff. And you get reduced vascular dilation, endothelial function, but the big hit's in the mitochondria. And it's an amazing oxidant stress hit. And so that, I think, is a right target for therapy, too.
Hi, Alpresha, invasive cardiologist. You know, we go to all these conferences and listen to lectures on PAD. Dr. Hyatt, I've not heard a single more elegant lecture than you've given today. Thank you so much in assessing. And my question is something I struggle with, and I'm sure most of us struggle, is this concept of aspirin and where we are and where we are headed. So as years have gone by, last 2-3 decades, we've become more and more critical and doubtful of what aspirin really means to our field, whether CAD, PAD. Is days for aspirin monotherapy gone? what is lacking in aspirin? Because there is a platelet inhibition it does. Is it a bigger dose? Is it something? Because every time we piggyback aspirin to another agent, it sure works. It's like a wide receiver, who that quarterback needs.
Yes.
So aspirin always makes a difference when you piggyback with the clopidogrel, rivaroxaban, but somehow the monotherapy always comes out on the losing side. Any thoughts, and what is the future? Where does aspirin go from here?
Well, gosh, I think your interpretation is exactly mine. Aspirin monotherapy is probably not placebo, but it's not much better than placebo, and so we can do better. And I also think you're right on. Aspirin on its own doesn't do much, but you combine it with something else, and you see magic happen. And so I think in the most recent evidence where you have low-dose factor Xa inhibition alone, it's not much happens. It's sort of beneficial. You combine it with aspirin, it works like magic. And so I don't use aspirin monotherapy in my patients. So I've got a large cohort of people with stable PAD. They're on clopidogrel, not aspirin. They go to the cath lab. There's not much evidence for DAPT in that setting, so we typically go short course DAPT, maybe 1 to 3 months at most. But what are we going to do long term? I mean, how are we going to keep these people alive 5 years after the procedure? And that's where these new data come in. And so my practice will change, I think, when it gets approved, to using low-dose rivaroxaban, if the insurer people will pay for it, with aspirin, and after intervention, it's probably going to be the same cocktail. So we need something new. You're absolutely right.
Can I get one more question? Well, again, great presentation. In almost all these trials, the patient with the end-stage renal disease gets excluded. And yet, probably 40-50% of the lower extremity work we end up getting presented with are patients who are on dialysis.
Yep.
And their disease burden is massive. And you talk about MACE and Mayo, those are the populations who would benefit most, but usually get excluded from the trial because they're too complicated.
Yes.
Any thoughts on the way forward to helping that group?
Boy, you hit another thing that resonates with our group clinically. When you're on hemodialysis, it's like nothing works. And if you look at one of the FDA reviews was on the SHARP trial, which is a Simva plus ezetimibe in people with end-stage renal disease. If you weren't on dialysis, more LDL lowering seemed to help. If you were on dialysis, nothing works. And so I think in the peripheral world, we see a lot of end-stage renal disease, and those people seem to have non-modifiable risk, just like you're saying. And you try to maintain their quality of life, but to think that you're going to extend their life with these therapies, I don't know. We don't stop treating them intensively with LDL reduction, blood pressure, all the things you typically do. But it's really frustrating. And my question is, and I don't want to be too negative, I just don't know how modifiable you are. If you're not on dialysis, you still have some room to move. But when you get on the machine, it seems to be over. And the leg doesn't do too well either.
Well, we're at the top of the hour.
Thanks.
Will, thank you for an elegant talk.
Thank you.